Rapid fire pulmonary CCS cases review. Let's begin. Dyspnea. The differential diagnosis of dyspnea can be divided into three parts. It can either be due to some cardiac cause, or due to some renal cause, or due to some respiratory cause. So let's look at the cardiac causes first. So in the cardiac causes, we have congestive heart failure and acute myocardial infarction, whereas in the renal causes, we have acute renal failure. And in the respiratory cause, we can further divide it into like two parts. The one that are related to, of course, like some sort of an infection or edema or embolism, right? All of those which have PE in their names. So pulmonary edema, pulmonary embolism, or pneumonia, and those that don't have PE in the name and are actually by A and C. So A represents acute respiratory distress syndrome, and C is for chronic obstructive pulmonary disease. So a quick review: whenever we have a patient with dyspnea, we have to think about three main causes. One would be the cardiac cause, acute MI and congestive heart failure, which we can rule out by a chest x-ray or troponin or cardiac enzymes along with ECG and echo. And acute renal failure, which we can rule out by basic metabolic profile. And then we have the chest causes, which are divided into PE and AC. And the PE will include pneumonia, pulmonary embolism, pulmonary edema, along with, of course, pneumothorax. And for AC, we have acute respiratory distress syndrome, and for C we have chronic obstructive pulmonary disease. Now let's go through these cases one by one and see what are our goals for diagnosis and what are our goals for treatment. So beginning with the COPD exacerbation, we can divide it into a step ladder pattern of like two main things that we have to do in the diagnosis. First of all, we have to confirm the diagnosis, and after the confirmation of the diagnosis, we have to establish the cause, that what is the particular virus that or bacteria that is involved in causing this particular exacerbation. So in order to confirm the cause, we have two tests, which are chest x-ray and sputum stain and culture sensitivity. So chest x-ray will show that it is an exacerbation, and then of course in sputum stain, if you have some bacteria, you can visualize it, and culture sensitivity will prove that bacteria. So that's confirming the diagnosis. Then you have to confirm or establish the cause, which is with the viral panel or the antigens for the bacteria, and that includes RSV, respiratory virus panel, as well as Legionella antigen. So just a quick review: for the diagnosis of COPD, we divide it into two main groups. The first would be to establish the diagnosis with an X-ray along with sputum stain and culture, and then to establish the cause, we are going to do an RSV virus test and respiratory virus panel along with the Legionella antigen. Now comes the treatment. Again, treatment can also be divided into like two main parts, just like we did the diagnosis was divided into two main parts, and we had two main goals. So we have two main goals of treatment. One is the support of airway, breathing and circulation, right? And then we have the exact treatment that we are going to do for the cause, right? So the support for the airway, breathing and circulation would be in the form of like, of course, oxygen, and if needed, if the patient has breathing difficulty, then we can give him albuterol along with ipratropium, right? So this is the supportive general treatment for breathing. And then we have the specific treatment. You know that COPD can basically an infection that is triggering the exacerbation, and that infection is causing inflammation. So you have to treat both the infection and the inflammation, right? So therefore, for the infection, you can give ceftriaxone with azithromycin, and for the inflammation, you are going to give prednisone. So a quick review of COPD treatment: we are going to divide it into two parts. One would be the general or the supportive treatment, in which you are going to take care of the airway, breathing and circulation, and amongst this is the supplemental oxygen along with for the breathing improvement, albuterol and ipratropium. Then is the specific treatment. For the specific treatment, you have to treat the infection that is causing the exacerbation, and so empirically you're going to start antibiotics such as ceftriaxone and azithromycin, and then for the control of inflammation, you're going to give him prednisone. Okay, and then for the further prevention, of course, you're going to give him pneumococcal vaccine, so that you don't have exacerbations due to pneumococcal pneumonia in the future. Now we have pneumonia. Again, for pneumonia, what are the goals for diagnosis? The goals for diagnosis are same as COPD. What were the goals for diagnosis of COPD? Again, pneumonia can be bacterial or viral as well, right? So we are going to confirm the diagnosis first of all with chest x-ray and sputum stain and culture sensitivity, and then we are going to establish the cause with the respiratory RSV respiratory syncytial virus test, or the respiratory virus panel, or you can also do like the influenza panel, and then the Legionella antigen in order to rule out Legionella pneumonia. In the treatment, again, the treatment is also the same. Your steps are the same, that you're going to do supportive ABC, which includes giving oxygen and bronchodilators, albuterol and ipratropium if needed. And then for the specific treatment, there's just one difference from the COPD treatment. In COPD, we were treating both the infection and the inflammation, because I said the COPD is actually an infection which has triggered inflammation. But for pneumonia per se, it is basically just an infection and does not have any inflammation. Therefore, you are going to avoid prednisone and any glucocorticoids and just treat it with infection and antibiotics treatment such as ceftriaxone and azithromycin. And of course, like as a precaution for the prevention, for next time, you're going to advise the pneumococcal vaccine and smoking cessation if the person is a smoker. Next comes pulmonary embolism. Again, for pulmonary embolism, you have two main goals. First main goal is to establish the cause, right? And after establishing the cause, the second main goal is to establish the diagnosis. And after establishing the diagnosis, the second main goal is to confirm the cause. Where did the embolus actually originate from, right? So first of all, to confirm the diagnosis, we have three steps, or you can say ABC. And one would be the simplest test, the D-dimers. Second, a little advanced, which is chest X-ray. And third, the CT contrast or CT angio, in order to like short confirm the diagnosis. Or if the patient is pregnant, we can also do a VQ scan instead, right? So these are the three basic steps with which we will confirm the diagnosis: D-dimers, then chest X-ray, then CT angio or CT contrast, or VQ scan if the patient is pregnant. And then in order to confirm the cause, we are going to do a lower extremity Doppler. And again, for the treatment, like what is the main like goal? One would be the supportive treatment. Of course, if the patient has low oxygen saturation, then you can give him oxygen. But of course, like since there is an embolus, so oxygen might not do as much. But still, for the breathing support, you can give him oxygen. And for the definitive treatment, of course, look at the pathophysiology, look at the cause. The cause is basically that there is an embolus and you want to dissolve that embolus. So once you are in the hospital, you want to dissolve that embolus rapidly, and that would be by giving IV heparin. And then once you discharge the patient, you can discharge him on warfarin or rivaroxaban. And always remember, before starting heparin, always do PT APTT. So heparin and PT APTT go together. And once you're going to discharge him, discharge on warfarin or rivaroxaban along with periodic PT monitoring, and also counsel the patient regarding the side effects of the anticoagulants such as bleeding. Okay, so this was pulmonary embolism. Let's move on to fat embolism. So for fat embolism, again, like think what should be your goals for diagnosis. Your goals for diagnosis again would be to establish the diagnosis, like to confirm the diagnosis. So in order to confirm the diagnosis, let's do first of all proceed from simple to complex. So the simplest test for here would be the chest X-ray, and after chest X-ray you can confirm the diagnosis with CT chest. And the treatment, again, what are your goals of treatment? Do you have any definitive treatment? No. In this situation, the only treatment you have is supportive. So this is the difference between the treatment of fat embolism and pulmonary embolism, that for pulmonary embolism you do have a definitive treatment where you can lyse the clot with anticoagulants. But for fat embolism, you don't have a specific treatment. So your mainstay of treatment would be just supportive with airway, breathing and circulation. That involves intubation, mechanical ventilation for airway and breathing. Along with, you can give oxygen, and for the circulation you're going to give fluids, but you're not going to give heparin. Why? Because this is just a fat embolism, and heparin will do nothing to dissolve the fat embolism, whereas heparin can actually dissolve the pulmonary embolism because it's a real clot, right? Okay, so this was fat embolism. Now let's move on to cystic fibrosis. Again, for cystic fibrosis, we have a battery of tests, and we are going to divide these tests again into like three main steps, right? So the three main steps are going to be: number one, you're going to confirm the diagnosis. Is it really cystic fibrosis? And you will confirm it with number one, fecal fat, and number two, with sweat chloride test. Then after that you have to establish the infection, and in establishing the infection you can do two things. You can do some sort of panels or you can do some sort of cultures. So for the cultures you can do a blood culture or a sputum culture, right, and as well as a sputum stain. And in order to establish the infection for the panels, you can do the panels just like we did for COPD exacerbation, RSV, or respiratory or influenza virus panel, right? So these are the three main steps for cystic fibrosis goals of diagnosis. And the first step would be to confirm diagnosis with fecal fat and sweat chloride test. Second test would be to establish diagnosis with blood and sputum, or basically culture sensitivity of these. And third step would be to establish infections with a panel such as respiratory syncytial virus test or respiratory panel or influenza test. Coming back to the treatment, again, treatment is divided into general or supportive measures and specific treatment. And the specific treatment is also further divided into GI treatment and pulmonary treatment. And you already know that the cystic fibrosis is such a disease which basically affects your GI system and specifically the pancreas, because pancreatic secretions become dehydrated and insippated, and similarly it affects the pulmonary secretions, and therefore it causes like all these pulmonary signs and symptoms, right? So first of all, for the supportive treatment, right, for the supportive treatment, what can you do? You can help to improve the breathing by giving oxygen or albuterol, right? And then for the GI treatment, if one thing is the pancreatic enzymes, right? And for the pulmonary treatment, for the control of infection, you can give him piperacillin and vancomycin, right? So these are the three steps: supportive treatment with oxygen or albuterol, the GI or dietary supplementation with pancreatic enzymes, and the pulmonary treatment of infection with piperacillin or vancomycin. And then we have the preventive treatment. In the preventive treatment, again, we have three steps. So remember, for cystic fibrosis, this is a lifelong chronic disease and we don't have such a definitive treatment for it. Therefore, prevention is crucial, right? And in the future, preventing attacks or exacerbations of cystic fibrosis. So one would be the dietary supplementation. Again, since I said it's affecting the GI system, therefore you have to give vitamin supplementation, specifically fat soluble vitamins such as A, D, E, and K. And for the subsequent control of infections, that the person does not have infection subsequently, you're going to give him vaccine, and that is the influenza vaccine. And you're going to refer him to specific cases for specific disease control, and that would be for chest physio, for of course the respiratory symptoms, and the cystic fibrosis care center. So that is the prevention of cystic fibrosis. Now let's start sickle cell acute chest syndrome. So again, the same thing for sickle cell acute chest syndrome. First, establish the diagnosis, then establish the cause. Establish the diagnosis with the simple test, that is chest x-ray, that would show you that the patient is having acute chest syndrome, and then establish the cause, that it's just not any infection that is causing this, but it's actually sickle cell. And to confirm it, you can do a blood smear where you can see sickle RBCs, or as well as like if there is some sort of hemolysis taking place, then you can also see schistocytes, and you can also do hemoglobin electrophoresis that will show you sickle cell trait or sickle cell disease. Coming on to the treatment of sickle cell acute chest syndrome is very important and very comprehensive, and I have divided it again into like three main steps. So we have step number 1, step number 2, and step number 3, and I have labeled them as step number 1 with the general supportive. Number 2 is the specific treatment, but the treatment is specifically for blood. Over here, you know that the main cause is that there is some problem with the blood, and on that problem with the blood there is some superimposed infection. Therefore, the specific treatment will also be divided into two parts. One would be the specific treatment for the blood issue, and one would be the specific treatment for the infectious issue. Okay, so let's begin with the general supportive treatment. For the general supportive treatment, you're going to give him oxygen for breathing, IV fluids for circulation, and morphine for pain control. So oxygen, fluids, and morphine will cover your A, B, C, and pain. Then we have the specific treatment for the blood. Since you know that this is a disease in which there is actually sickling, right? So how can we basically prevent the sickling or dilute the blood such that there is lesser sickling, right? So since these patients have like sickled RBCs and the RBCs hemolyze rapidly, so they are rapidly in need of like folic acid in order to make new RBCs, and hydroxyurea, which is basically going to increase the hemoglobin F concentration and therefore lead to less sickled RBCs, right? So hydroxyurea and folic acid along with blood cross match and transfusion again to dilute the blood blood and lead to dilute the blood by introducing normal blood instead of sickle blood, and leading to less hemolysis, less clogging of the microvasculature. So blood cross match and transfusion. This was the specific blood treatment. Next on, we have the specific treatment for infection. So again, the bacterial cover with ceftriaxone or azithromycin, and consult infectious diseases or hem-onc. And once you're going to discharge the patient, you know that these patients have functional autosplenia because of the sickled RBCs. They are clogging the microvasculature and can lead to splenic autoinfarct. Therefore, before you discharge the patient, remember to give pneumococcal and meningococcal vaccine. And yes, I forgot that one other thing. You also have to give this patient penicillin in order to prevent repeated infections, right? So just to summarize sickle cell acute chest syndrome, the mainstay of goals or the of diagnosis or the goals of diagnosis are to establish first of all that this is sickle cell acute chest syndrome with the chest x-ray, and number two is to establish the cause with a blood smear or hemoglobin electrophoresis. Then in the treatment you have three main goals. One is the general supportive treatment by giving oxygen, IV fluids along with morphine for pain control, since this is an acutely painful condition. And in the specific treatment, we have the blood specific treatment with hydroxyurea, folic acid, and diluting the blood with blood cross match as well as transfusion. Then the specific treatment of infection includes ceftriaxone with azithromycin along with penicillin, and then you're also going to consult the infectious disease and hem-onc, and before you discharge the patient, remember to give him meningococcal and pneumococcal vaccine. Epiglottitis. For epiglottitis, the goals of diagnosis are the same. We have to establish the cause first of all, and after that we have to rule out some other infection. So for establishing the cause, we need x-ray of the neck of the lateral of the neck. But if the patient is not like hemodynamically stable and the patient is actually having breathing difficulty, then don't wait for the x-ray of the chest lateral. Rather directly do direct laryngoscopy and intubate and mechanical ventilate the patient, and subsequently you can do x-ray chest to confirm the diagnosis and rule out infection by streptococcus by doing a strep culture and a rapid strep test if possible. Then for the treatment, again the treatment is the same. Do some general supportive measures and do a specific treatment. You know that epiglottitis is specifically caused by bacteria, therefore you'll have to give specific antibiotics for the infection. And for general or supportive treatment, it's the same. You're going to give him oxygen, intubate and mechanical ventilate, since acutely inflamed epiglottis can actually block the airway and cause the death of the patient. And for the specific treatment with infection, give him ceftriaxone and vancomycin, and they are going to give you both gram positive, very good gram positive, as well as MRSA, gram positive MRSA, as well as gram negative coverage. Next on, we have Croup. So it's basically a clinical diagnosis, but again, in order to rule out some other infection, you can do an x-ray of the neck. And the treatment is basically very supportive. So you're going to do ABC treatment, right, for airway, breathing and circulation. And since this is a sort of acute inflammation, so you're going to control the inflammation as well as you're going to give him some pain medication. So step number 1 in ABC, you can give him oxygen or IV fluids. Along with, to support the breathing, give him humidified air and racemic epinephrine. That is going to make breathing easier. Next on, for the pain control, you can give acetaminophen, and for the infection or inflammation control, giving dexamethasone, right? Okay, then we have PCP pneumonia. Again, for PCP pneumonia, the goals of diagnosis are divided into 3 parts. The first is, first of all, to establish the infection with PCP pneumonia, and that's a very simple test of chest x-ray, which is going to show you interstitial infiltrates. And if the patient also has vaginal candida, then do a vaginal cervical wet mount in order to look for the hyphae of candida, right, and do a high vaginal swab. So that in this way, in the pneumonia, PCP pneumonia, that's why they might specifically give you vaginal candida, just to give you an idea that this person is having opportunistic infections, and you have to keep HIV at the back of your mind. Next on, we can confirm the cause that it's really HIV by doing an HIV viral load, CD4 count along with LDH, which is measured in HIV patients as a non-specific marker for pneumocystis jirovecii pneumonia, right? So first confirm the diagnosis, then confirm the cause in step number 2. In the third step, rule out specific infections. So you are going to do a blood culture, a sputum culture, along with hepatitis panel in order to rule out these any associated blood-borne or pulmonary pathogens along with any hepatitis pathogens, right? And in the specific treatment, again, for general treatment and specific treatment. So general treatment or support can be oxygen, or if the patient has such respiratory distress, you can intubate and mechanical ventilate and give IV fluids as well. And for the specific treatment, one is the control of infection and the other is the control of inflammation. So in the control of inflammation, if the patient has partial pressure of oxygen less than 70, then you're going to first give him prednisone, which will be followed by trimethoprim sulfamethoxazole. But if the partial pressure of oxygen is greater than 70, then you do not need to give prednisone beforehand. And for trimethoprim sulfamethoxazole, which is the specific treatment for PCP pneumonia, if the partial pressure of oxygen is greater than 70, you can simply give him an oral trimethoprim sulfamethoxazole. But if the partial pressure of oxygen is less than 70, then you will have to give him IV. So this is the treatment for PCP pneumonia. One is the general treatment, where it's oxygen and intubate and mechanically ventilate if the patient is having breathing difficulty. Next is the specific treatment for the inflammation, which is with dexamethasone if the partial pressure of oxygen is less than 70, and you will give this before trimethoprim sulfamethoxazole. And after this is the specific treatment of infection with trimethoprim sulfamethoxazole in the form of oral if the partial pressures are greater than 70, and in the form of IV if the partial pressures are less than 70. Now, and of course, like since this is HIV case, so for the infection you have to do a public health referral and notify the public health department of an HIV case, along with give pneumococcal vaccine in order to prevent pneumococcal pneumonia in the future. Next on, we have tuberculosis. So for tuberculosis, we have two steps in the diagnosis. One, we are going to establish the diagnosis radiologically, and then we are going to establish the diagnosis with blood, skin, or sputum. So for the radiological diagnosis, step number one, we can do a chest x-ray, and moving on, we can also do a chest CT. And for the blood, skin, and sputum, we can confirm with a PPD test or the interferon gamma radioassay, along with sputum for acid-fast bacillus and culture sensitivity. Then in the treatment, we have first of all respiratory isolation. We want to prevent the spread of this infection. Next on, we are going to do an ophthalmology consult before we start ethambutol in order to test baseline color testing, as well color vision, as well as color acuity, as well as visual acuity, ACUITI. Okay, and then next on, we have the specific treatment with the rifampicin, isoniazid, pyrazinamide, as well as ethambutol, along with the vitamin B6, and of course we will notify the public health department since this is a notifiable disease. So the goals for diagnosis for tuberculosis are, just a quick review, they are radiological diagnosis with chest x-ray or chest CT, along with the blood sputum or the skin diagnosis with interferon gamma radioassay, tuberculin PPD test, along with sputum for acid-fast bacillus and culture sensitivity. In the treatment, begin with respiratory isolation, consult ophthalmology for visual acuity and baseline color vision, and then proceed onward with the specific treatment of and vitamin B6, and do not forget to give him a public health referral. Next on, we have infectious mononucleosis. The goals of diagnosis would be, number one, to establish the cause, that is infectious mononucleosis, and number two, to rule out some other infections such as a strep throat. So first, we are going to do smear for atypical lymphocytes, and of course CBC will also show lymphocytosis, and then we can establish the diagnosis with heterophile antibody testing, and then we can rule out other causes with rapid strep test, and you can also do a CMV test in order to rule out CMV mononucleosis. And the specific treatment in this case is just supportive with acetaminophen, and you will avoid amoxicillin because it can cause rash in mononucleosis patients, and it's basically a viral infection, so antibiotics are not really beneficial. And avoid contact sports because the patient has splenomegaly, and any contact sports can actually lead to splenic rupture as well as hypovolemic shock and death. Next one, we have cyanide poisoning. So again, for cyanide poisoning, we'll go the same, that we'll establish the infection and then we'll rule out some differential diagnosis. So for establishing the cause, we can do like the lactate test, and lactate can help us differentiate between cyanide and carbon monoxide poisoning. And specifically for ruling out the cause, we can do a carbon monoxide blood test. Then for the treatment, if it's specifically cyanide poisoning, again the general supportive treatment with oxygen, intubate, mechanical ventilate, and IV fluids. And then the specific treatment would be with hydroxycobalamin or methylene blue, which is going to like basically reverse the cyanide poisoning. And if the patient is actually having carbon monoxide poisoning, then we can give him hyperbaric oxygen. Next on, we have foreign body aspiration. For foreign body aspiration, again, for diagnosis, confirm your diagnosis with a chest x-ray that will show you the exact location of the foreign body, and rule out some other cause such as laryngotracheitis with lateral neck x-ray. Next on, for the treatment, there's the general supportive treatment with oxygen or IV fluids, and then we have the definite treatment with bronchoscopy. Next on, we have sarcoidosis. So for sarcoidosis diagnosis, we have 3 steps. First, we are going to establish the radiological diagnosis. Next on, as well as the histopathological diagnosis. Next on, we can rule out certain other causes that can mimic sarcoidosis, such as HIV and TB. And thirdly, we will establish the associated deficiency, which is vitamin D deficiency, right? So first of all, let's confirm the diagnosis with chest x-ray or CT scan along with a lymph node or skin biopsy. Next on, rule out other causes with HIV or PPD test. And thirdly, establish associated deficiencies such as vitamin D deficiency, since 47% of the patients with sarcoidosis can have low vitamin D levels. In the treatment, mainstay is treat the main inflammation with prednisone, step number 1, and step number 2, treat the deficiency with vitamin D. Lung adenocarcinoma. The goals of diagnosis for lung adenocarcinoma are 3. First of all, we want to establish a radiological diagnosis. Then we want to establish a histopathological diagnosis. And then we want to rule out certain infections. So firstly, do a radiological diagnosis beginning with the chest x-ray, then do a CT chest, followed by a CT head or the CT abdomen in order to look for METs. Secondly, establish the histopathological diagnosis by doing a bronchoscopy along with a biopsy. And thirdly, rule out infections such as tuberculosis with PPD and sputum culture sensitivity, and you can also do a sputum cytology. In this specific treatment, it's a lung cancer, so we'll have to remove the cancer, and the patient might also need chemo. So in this specific treatment, we will have consult surgery as well as consult oncology. And that concludes our pulmonary rapid review, pulmonary CCS cases review. If you like this video, please share, like, and subscribe, and follow for more such content. This is all for now.